Brio Medical Cancer Center in Arizona. He's also the chairman of the Scientific and Medical Advisory Board for Vitamin C International Consortium Institute. So thank you very much, and I will welcome Dr.
I want to thank AAOT, Dr. Frank Schauenberger, and everybody here for allowing me to speak. It's always great to focus on doing what we do as physicians, which the word physician in Hebrew, Raphael, means healer, the word doctor in Latin means teacher. So our very goal of what we do is we're teachers that heal. So what I want to do today is I want to talk about some basics and fundamentals of vitamin C, and I really want to apply them with some recent research in the field of oncology and the treatment of cancer, and so as to improve the application of pro-oxidative therapy, evidence-based wise, not just in cancer, but in other treatment strategies of illnesses. I have a dear friend who's actually my coach, and she's got a book coming out. Now, the logo is not available, the book is not ready, it's being written, but the title is Bold Mission. And I love it because this acronym stands for BOLD, it stands for believe, to help our patients here in this context believe. We have to help them to own it, we have to help them to live it, and we as our physicians, our job is to not just help them to believe they can be healed, but not just to help them to own it, but to help them to actually live it. And she has the D as duplicate, but what I would say is we need to deliver it for our patients. So I want to go through several different objectives here. Vitamin C is a very long history, sodium ascorbate versus ascorbic acid, vitamin C fundamentals, the basics, vitamin C metabolomics, vitamin C from COVID to cancer. Dr. Levy's already talked extensively about that, so I'll touch briefly on that. Mechanisms of actions, and then specifically the pro-oxidative effect of vitamin C in high dose as guided by recent research. So let's talk about vitamin C history. Just really briefly here, because Leora touched on this very, very nicely. Really, the hypothesis began with William J. McCormick, MD, in 1954, where he hypothesized that vitamin C deficiency actually played a role in the metastasis of tumor. Now, fast forward into the 70s, and we had Ewan Cameron, a Scottish physician, actually looking at ascorbic acid, cell proliferation, and cancer. Then he combined with Alan Campbell to really focus on the orthomolecular treatment of it. Then Frederick Klenner, as many have mentioned this weekend, dosing up to 300 grams in cancer and a wide variety of other illnesses. Now, everybody focuses on Linus Pauling, rightly so, but he was one half of a famous duo, Ewan Cameron and Linus Pauling. They looked at 10 grams IV vitamin C, published in 1976, and then repeated in 1978. In 1976, what they found is they found a 4.2% increase in the survival time, up to 210 days. They repeated that in 1978, and what they found is there was a 5,400% increase in 1 year survival with 10 grams of IV vitamin C in a very short form, then followed by oral. Now, Ewan Cameron is Scottish. My oldest daughter, she's graduated from the University of Aberdeen in Scotland. The Scots always seem to find their way into history, and so he's that less famous duo here, so shouts out to the University of Aberdeen. Abram Hoffer basically advanced this with 10 grams oral vitamin C. Then we went to the Asian continent, with Murata, Mushige, and Yamaguchi, looking at doses of 5 to 29 grams of IV vitamin C. I would garner this as still low dose based on animal studies. Less than 30 grams is not reaching that plasma ascorbic acid level of 1 millimolar, which is cytotoxic to cancer cells. Then we reach the Mayo studies. Mortel, Cregan, and Fleming. What they sought to do was to duplicate what Linus Pauling and Cameron did. But what they failed to recognize was the difference in oral bioavailability and IV bioavailability. And so then what happened is they set the narrative that still exists today for 40 years. But what they failed to recognize is that their oral route was never going to provide the same therapeutic effect that Pauling and you and Cameron provided, but they set the political narrative and it exists today. More mainstream, you have to give hats off to the pioneers like Reardon, Robert Cathcart, the recently deceased Richard Davis. And of course, more modern here, Jeannie Driscoll really doing some great work out in Kansas City. Paul Merrick, as Leor has mentioned, and his groundbreaking research on really low-dose IV vitamin C, but in sepsis. And then, of course, I'd be amiss if I didn't mention Dr. Thomas Levy. These people are really setting the stage for, I think, what's going to be a very exciting century related to vitamin C. So I want to follow one of my patients through this course of this lecture. This patient is dear to me. She's KD, so I don't want to mention her name. She was a G1P1. She presented on April 30th, 2019, and she was diagnosed with ERPR positive HER2 negative left breast cancer. Now, this was in 2010. She underwent a bilateral mastectomy. She had 4 of 24 positive lymph nodes on her left side, and she was deemed cancer-free at that point by her oncologist. She refused chemo and radiation, and she sought to seek naturopathic care in the valley at that point. She presented to me in 2019 after she had actually recurred 1 year later from her cancer-free state. So she came to me with this huge 8-centimeter mass, the worst lymphedema I've ever seen in the left arm, on oxycodone, on morphine, and she was just in a terrible spot. So let's talk about sodium ascorbate versus ascorbic acid, because this is a debate that so many people will talk about, but it's really foundational to the other debates about vitamin C. Now, Leor's talked quite a bit about the different forms of vitamin C, but I would add this kind of caveat when you look at physiology and biochemistry. When we look at the different forms of vitamin C, and Leor correctly touched on the pH, and I think that's really key, and I'll show you that in a second, why that's key in pro-oxidative therapy. But what we're looking at is the different forms of vitamin C, and we're looking at all the metabolites of the family of vitamin C. When we look at vitamin C, it's not just what form do we give, it's the intended effect that we're after. And we need an intended effect to give us the result. So whatever dose we choose, whatever product we choose, we need to make sure we achieve the intended effect. If we do, then that's the product we need to use, that's the dose we need to achieve, as guided by the evidence. Many call it a vitamin. So what is a vitamin? Well, I'm a nerd, I love the root history of words. Out of history comes what words mean. Words really are just a context and a time of history. And I think if you disconnect history from words, you disconnect their meaning. So the word vitamin was originally coined by a Polish biochemist by the name of Casimir Funk. And the thought here was that there are these things called amines that are required and essential for life. Just so happens that the word life in Latin means vita. And so what we have is vitamin, or vitamins. Now, Leor correctly mentioned that we lack the enzyme because of mutation to produce the enzyme gluconolactone oxidase. And what that does is it disenables us to make vitamin C. And because of that, that essential enzyme creates a deficiency that is essential to our biochemical function. Is it vita? Is it amine? But it's vita. It is vital to what we need. So I would say it's a vitamin, but more important, what I would say is that our patients know it as vitamin C. And so if we want to engage our patients to educate them, we need to help them to understand that vitamin C is not just what its name is, but what it actually does. So what is it? Well, is it vitamin C? Is it the reduced form of vitamin C, ascorbic acid? Is it dehydroascorbate? Is it an electron donor? And I would say that that is more what it is. Is it a drug? There is a move to reclassify vitamin C as a drug. I don't think that's by chance. I think that is to be able to regulate it as such. A lot of the conventional literature is actually referring to it as a prodrug. I would say what it does is it delivers hydrogen peroxide. And then there's pharmaceutical ascorbic acid. So what is it? It's really all of these in context, depending on dose, depending on the environment. But it's a deliverable hydrogen peroxide product. And it supports both redox homeostasis and it disrupts redox homeostasis, intentionally dictated by the environment. So the future of medicine, especially as it relates to cancer, is genomics, epigenomics, proteomics, and metabolomics. It's precision medicine. It's customized medicine. And really metabolomics is something that's already been well discussed and described, especially as it relates to hormones. But we're talking about over 38,000 different metabolites. And when we look at things, we look at the parent compounds and we fail to recognize that it's the metabolites of those parent compounds that can have equally the same effects, if not more dramatic. Not only is vitamin C a part of history, but vitamin C is a part of the future. And we have to understand that whether we want to or not, vitamin C and therapies like ozone, they are the flagships of alternative medicine. We need to use precision and exact science in our utilization of them, even if conventional medicine, of which I am a conventional medical doctor, do not. So I referenced this reclassification of vitamin C as a drug. So let's get into my nerdiness here and talk about the etymology of this word. It originates in Anglo-Saxon 14th century as any substance used in the composition or preparation of medicines. Fast forward to the 16th century, it's a poison. Fast forward to the 19th century, it's an opiate and a narcotic. Now, if you just look at this from just an etymological perspective, from a historical perspective, or an obvious perspective, vitamin C is not a drug. And I'll show you how pharmacologically, but also the basics and the fundamentals, it's not a drug either. It's its intended effect that we're after. We want to avoid this reclassification push that we've seen done before and we're seeing played out right now with vitamin C. I'm a gynecologist by original training, and so as so many of us, we cut our teeth in hormones. So what I want to answer here from this slide is there a precedence for a small change in a molecule from sodium ascorbate to ascorbic acid to have such a fundamental difference in effect or tolerability or compliance? And I would say all we got to do is look at the hormones. Progesterone, just a simple acetate at this 21 position, makes a difference between progesterone and medroxyprogesterone acetate. Medroxyprogesterone acetate is not a drug I would give to my worst enemy. That is a terrible drug, but progesterone is something that women can actually benefit from. But I think we need to have a caveat there as well. Weeby in the literature has actually described how progesterone can be metabolized to what are called 5-alpha pregnated products, and that can actually promote breast cancer. So we have to understand the metabolism of hormones. Estrogen, estradiol, estrone, and estriol. Talking here about the effects of just simply at the 17th position, a hydroxyl group versus a carbonyl group. Its effect being dramatic in its estrogen receptor affinity. Estradiol pretty much equal to estradiol and estrone, and to ER alpha and ER beta. Estrone more predominant on ER alpha and thus more pro-inflammatory and more pro-proliferative. Testosterone. Everybody focuses on low testosterone, but what I tell people about giving testosterone to men in low testosterone is understand that sometimes hormones are the effect, they're not the cause. That testosterone in men could be because of an environment that is promoting low testosterone. Doesn't mean it's helpful, but giving the testosterone in that context of that environment may actually propagate some things you don't intend. So testosterone versus dihydrotestosterone versus 3-alpha-androstenediol. These different androgens have different effects. The 3-alpha-androstenediol can even bind to the estrogen receptor. So if you're talking about breast cancer, that has a huge impact. And of course, to be amiss if I didn't mention the deiodinases effect on thyroxine, triiodothyronine, and reverse triiodothyronine. But understand, in this discussion of hormones here, what I'm referencing is the genomic classic hormone signaling. There's non-genomic hormone signaling as well that completely bypasses the receptors and plays a significant role in cancer. So why does this esoteric debate beyond history or my love for words matter? Because it's about achieving a therapy, the intended effect, that's tolerable and compliant by our patients. So the pH neutrality of sodium ascorbate allows us to achieve this high dosing of tolerability and compliance to achieve the results that we need for our patients with this thing called cancer. So here this patient, she's weighed as little as 98 pounds to as high as 115. She's a little person, you'll see her picture here at the end. And what we were able to do here is her dose has ranged from 175 grams to 225 grams every 3 days a week for the better part of 2 years. And the reason why she's needed that is not because of her weight, it's because of something I'll talk about in a second. So the fundamentals, the basics of vitamin C, and I think this is what really I hope you take home, because this is going to be key to the pro-oxidative effect of vitamin C, especially in the treatment of cancer. When we look at the fundamentals, it's really about the frequency, the duration, the dosing, the bioavailability, which was at the crust of the difference between Mayo studies and Cameron and Pauling, pharmacodynamics and pharmacokinetics. And I love this quote from Linus Pauling. He always seems to reach out of history and touch us. Although physicians, as part of their training, are taught that the dosage of a drug that is prescribed for the patient must be very carefully determined and controlled, they seem to have difficulty in remembering that the same principle applies to vitamins. All right, so let's bring back some nightmares here, talking about pharmacokinetics and pharmacodynamics. I can remember in my medical training, the pharmacy part of my exam, thinking, why do I need to know pharmacokinetics and pharmacodynamics? That's what a pharmacist is for. But little did I know at the time that no, pharmacist's job was to actually block my recommendation for prescriptions of ivermectin and hydroxychloroquine. So we have to move beyond that and understand that these principles are key. So pharmacokinetics is simply just an acronym, as LACME. Liberation, distribution, elimination, metabolism, and excretion. Okay. So pharmacokinetics is just simply a drug being distributed throughout the body after it's absorbed or delivered to its intended site for its effect. Pharmacodynamics is simply the drug concentration at the site of action and its resulting effect, whether that be the intended effect or whether that be the adverse effect. And I think this slide here encompasses pharmacokinetics really well, because what we're looking at here is on the left of your screen, yes, is plasma, and what we're looking at on the right is the extracellular fluid. And bioavailability gets into the core of some of this, because what we see there in the plasma is ascorbic acid here being delivered, losing an electron twice now to ascorbate radicals, eventually coming down to produce, through the Fedden reaction, hydrogen peroxide. The difference here is that in the plasma, we have red blood cell glutathione peroxidase, and we have catalase that actually eliminate really any detectable hydrogen peroxide. But in the extracellular fluid, what we see is a different environment dictates a different effect. And so what you see here is actually